Hi rehabbers, it's Kevin from the YouTube channel Rehab Revolution, and this week's learning is about leg pain in patients, in particular differentiating vascular claudication from neurogenic claudication in patients that we may see in an outpatient clinic. So the aims of this short presentation will be to understand what claudication is, be able to differentiate between vascular and neurological claudication, be able to identify risk factors that could suggest being more at risk for vascular claudication symptoms, and be confident in incorporating vascular screening as part of your MSK assessment, and also in addition to the video of the actual assessment itself that was released last week. So, what is claudication? So, essentially, intermittent claudication is leg pain, which is worse with activity and eases with rest, sitting. There's two main types. So, obviously, vascular and neurogenic. And although vascular can be further subdivided to arterial and venous claudication, we are today focusing on arterial claudication versus neurogenic claudication to try and explain patients' symptoms. So, I personally learn best trying to put things into practice as opposed to just this is what claudication is, these are the things you look for. So, based on that, this is a patient case study of a patient I saw a long time ago, and he presents in clinic with lower back pain and bilateral calf pain to the Achilles. He is 72 years old. He's had a 3-year history of his symptoms with no injury, and his past medical history includes diabetes, high blood pressure, high cholesterol, and joint replacement surgery. In particular, he has had surgery for a knee replacement and a hip replacement. His medication that he is on are statins, high blood pressure medication, metformin, and his general health, he is a smoker, he doesn't drink alcohol, and his BMI is 42. So, before we move on, just take a minute, you can pause this and then come back to it, but take a minute just to see if you feel there are any possible vascular risk factors based on the history that I have just given you. When you've written them down, then press play and then we can carry on. So, the risk factors for vascular claudication that this patient has include smoking, high blood pressure, diabetes, high cholesterol, high BMI, and age. Now, this study is a little on the older side, so by Razzo and colleagues, 2014, and they discovered or reported, that the risk factors for vascular pathology are such things as age, so 65 years and older, or 50 to 54 years old, but with other atherosclerotic risk factors, including hypertension, diabetes, high cholesterol, current smoker or past smoker, and chronic kidney disease. Now, if we go through these individually, you can see that if we look at the high blood pressure, if we look at diabetes, if we look at high cholesterol, then the odds ratio, which is OR here, so we start with the high blood pressure, which is number 1. The OR, the odds ratio, is 1.5, but the 95% confidence interval is 0.9 to 2.2, so it crosses number 1. So that means that it isn't significant. Same with diabetes. The confidence interval is 1 to 2.3, so it does include 1, so it isn't significant. Same with the high cholesterol, it's 1 to 1.8. Now, it doesn't automatically say that these are not important, but also with an odds ratio, this is not causal. So it does not mean that if you have high blood pressure and you have an odds ratio of 1.5, you are definitely 1.5 times more likely to develop it. It just means that the odds associated are 1.5 times more, not that you will definitely get it. Now, the smoking status of patients. So if you are a current smoker, the odds of you developing vascular pathology is just over 4 times more than if you were a non-smoker. And you can see that the 95% confidence interval is not including 1, it's 3.1 to 5.4, so this is significant, as is chronic kidney disease. So in particular, if you have an estimated GFR less than 60, you are 2 times more likely to be associated with an increased risk of vascular pathology. Again, the 95% confidence interval does not include 1, so it is significant. Now, these are risk factors on their own, but what happens when we combine them? So you can actually see on this chart from the authors that in the general population, if you have 3 of the risk factors we've mentioned, there is an associated increase in odds of just over 10 times more likely to develop vascular pathology. But it does not mean that you will definitely get vascular pathology. It is not causal, it's observational. So when you're screening your patients and you ask their general health, as we do, and we ask, are they diabetic? Do they have any problems with high blood pressure, high cholesterol? Do they have any problems with kidneys? Do they smoke? Then if they are saying yes, yes, yes to more and more of them, then it just means that there could be an increased risk. It doesn't mean, increased odds, not risk, increased odds of developing a vascular pathology. And it's something there just to think of as you are assessing the patient. So, going back to our patient, he reports his aggravating symptoms are pain on walking, so that's his back and his leg. He can walk to his local shop, which is about 800 meters. He used to walk quite fast, but he's got slower over the years. If he tries to walk faster, his leg pain worsens. He cannot walk further than 800 meters without resting. He has not been able to walk further than that distance for about 6 months. Standing in queues, so waiting for his shopping, for a few minutes makes his back pain worse, doesn't really change his leg symptoms or make his leg symptoms worse, Easing factors, when he stands still for a couple of minutes, his leg symptoms do ease somewhat, but his back pain does not, it increases. Leaning on a shopping trolley around Tesco's, so sort of pushing the trolley leaning forward, or if he's leaning forward on the sink when he's washing up, it reports that it eases his low back pain, but not his leg symptoms. Resting also seems to help his symptoms. So at this point, what is your differential diagnosis and what information do we have that may support this? So if you pause this video now, start making some notes, and then when you're ready, just start again. So the differentials are vascular claudication, obviously, otherwise that wouldn't be the title of the talk. But with vascular claudication, when walking, symptoms usually come on at a certain time and distance, which is generally reproducible. Walking slower can be easier, because obviously if it's vascular and you're walking faster, there's an increased metabolic demand. Neurological claudication, so walking, it can be variable and also can be changed by changing position. And the other differential is chronic degenerative lower back pain, as we put there, aggravated by walking, standing, and then leaning forward, so flexion movement eases, pushing, trolley, washing up. So, what the patient might tell us, which is obviously the most important. So, pain on walking obviously can affect, or it could be due to both neurogenic and vascular symptom causes. Vascular claudication, as we mentioned, usually comes on at a certain time, sort of distance or surface. Speed and intensity aren't changed. Neurogenic can be variable and can come on very quickly. Walking up slopes will still be problematic with vascular pathology because of increased metabolic demand, but can be easier for neurogenic pathology. Vascular, 1 to 2 minutes to settle, so symptoms take 1 to 2 minutes once he stops the walking, and reports that he didn't need to sit, bend forward, change position. This is usually, or these symptoms are usually needed for neurogenic. So if it was a stenosis, most people, they either sit, bend forward, change position, whereas with vascular, that isn't the case. Standing eases the symptoms generally for vascular, but can aggravate if it's neurogenic or if it's more of a degenerative mechanical back pain. Neurogenic symptoms also have the positive trolley shopping cart sign, while the vascular causes will be negative on this. Walking slower can be easier than walking faster for vascular patients. Walking upstairs, as we mentioned, can ease neurogenic symptoms because increasing the flexion at the spine, but vascular patients may find this more of a challenge. Another key sign could be with vascular patients that when they report that they have to drop their leg, move their leg out of the bed, dangle it off the edge to try and help their symptoms. So this infographic is from, as you can see here, Morley et al. 2018, and this just briefly talks about where the signs of vascular claudication are, where the causes are, and where the symptoms could be. So going on from what we've already talked about, what would you include in your objective assessment? So again, pause it for a minute, then do all of the, make up your notes, what you wanted to put in, and then press play. So this is the components of my assessment. So spinal range of movement palpation, neurology, so his myotomes, dermatomes, reflexes, straight leg raise, pulses, which if you've watched the video last time, you should be hopefully happy with, and if you haven't watched it, why not? The pulses here, so femoral, popliteal, dorsalis pedis, posterior tibial, but really important is this is not the gold standard for vascular, so just because you can pick up the pulse does not mean that there isn't a vascular problem, and vice versa. I also looked at things like temperature of the limb, capillary refill test, the colour of the skin, so dry, shiny changes, ulcers, tissue loss on the heels between the toes, as we talked about in the video, or areas of poor healing, abnormal nail growth, sort of thickening, loss of leg hair, cold feet, muscle atrophy. The Berger's test, which is not included here, there is some work on this where you essentially put a patient in a straight leg raise position and for a certain amount of time. In a normal patient with normal vascular systems, then the body should be able to overcome gravity to get the blood up. So there will be colour changes in patients that do have vascular issues. And then when you come back and sit down on the edge of the bed, initially the limb can be paler than the unaffected side, and then you get a rapid refill, so then it goes quite red. Again, this is not the gold standard, but it is one of the tests out there. So the outcome of the patient objective assessment, as you just mentioned there. So these are the things that can be done. At the bottom, I have put ABPI, the toe brachial index testing. When I say not us, I mean in particular not me. I am not trained in that. I am a physiotherapy specialist, not one of the excellent vascular nurses, doctors, and things like that. So on this patient, on his testing, basically spinal extension reproduced his lower back pain, but did not change his leg symptoms. Again, spinal palpation reproduced his symptoms, but not leg pain. Neurology was fine, and on the pulses, I couldn't detect the posterior tibial pulses. However, as I mentioned in the video last time, that doesn't automatically mean there is a problem. Sometimes it's operator error, in this case me. Sometimes they can be in slightly different areas, and a small proportion of patients don't actually have it. The capillary refill test and things like that, that was all fine, apart from a colder right foot than his left. And when we did the Berger's test, it was positive for foot colour changes. So at this point, my diagnosis was that, oh sorry, actually go back one. So if patients have neurogenic claudication, as we mentioned, symptoms are normally triggered with standing, alleviated with sitting, can be localized above the knees, positive shopping trolley, shopping cart sign. But the key thing is, if it is neurogenic, they will usually change position. Whereas vascular claudication, they don't need to change position, they just usually have to stop what they're doing because it decreases metabolic demand. So going forward with our patients, when you are asking patients their medical history, so are they diabetic, are they epileptic, ignore the epilepsy actually, if they're diabetic, are there any problems with cholesterol, are there any problems with their kidneys, things like that, then it starts to make you think, okay, there possibly could be vascular risk factors. And then we start to look at their symptoms. So again, if a patient has neurogenic, so their cause is nerve leg pain, then most of the times their symptoms will be due to things like walking. It can be variable distances and times, eased when they change position, so sitting, bending forward, can be leaning forward on a trolley. But with vasculogenic, so if they bend forward, lean forward, does not make much difference. If they stop, sort of stand still or walk slower, there is decreased metabolic demand, which might make you think vascular. But also, really, really important is another factor is that it's generally reproducible. So a patient with vascular symptoms doesn't usually say that if they walk for 4 minutes one week, their symptoms come on. The next week they can walk 15 before the legs come on, and then the week after it's 3 minutes. So it's generally quite reproducible. So we've got our suspicions, we've identified risk factors, and we've seen some symptoms which make us think this could be vascular. So at this point, I want you to make a note of any other professionals that you may need to liaise with. And then when you're ready, you can just press play. So I put on here things like, and this is based on where I work in Cambridgeshire, obviously GP, diabetic nurses, we've got the Desmond programme, vascular team, physiotherapy, smoking cessation, healthy you, and I'm sure there's a lot more that you could think of. Now, really important, and it's really important to talk about this, is that this is not a training to say that once you've done it, you can definitely identify vascular things and act on it. So this is not saying that we are trying to step on other professionals' toes, but when I work as an advanced practitioner or with FCPs or people that may not have seen the GP first, our job is to identify possible risk factors and then act on it. So in the case of this patient, I would identify it and then write a letter to the patient asking for their vascular opinion, and then it is their medical expertise and decision to decide whether they do or not. So again, how to manage. So there is a good website, Circulation Foundation, which you can see there, which talks a lot about things. Main thing here is the risk factor modification, so modifying their risk factors, which essentially is all medical. So blood pressure reduction, smoking cessation, working on cholesterol, working on diabetes, as well as the physical side, which is exercise to gradually increase their activities. And there is a study there that generally shows for mild to moderate vascular claudication, a graded walking program can improve pain-free walking, it can improve walking distance, and it can improve quality of life. Although it's important to note that things like a 80-meter increase in pain-free walking, whether that's good enough for the patient, that's a different thing, but there are treatments out there. This, again, you can have a look at in your own time, but this is showing the effect of home exercise program on maximum walking distances for patients. What I would say is liaise closely with the doctors or the vascular teams before suddenly incorporating a vascular program. This is what the actual study consisted of. So walking 3 to 5 times a week for 12 to 36 weeks. Walking as tolerated, and then rest until they're able to start again and repeat and building up. And that program seems to give some interesting results. So, has your diagnosis changed that you thought of at the beginning? My diagnosis was chronic degenerative low back pain with possible vascular claudication signs and risk factors. And this is a really good take-home message to use in clinic based on the infogram in the BMJ from Morley and colleagues in 2018. Basically, if a patient has 3 or more risk factors, if there are less than 4 foot pulses, subjective signs of vascular claudication, so that is symptoms are reproduced consistently at set distance and eases quite quickly, and they don't need to change position. They have a negative shopping cart or trolley sign. Then I write to the GP to decide on whether further investigations are needed. This is obviously for the GP to decide, not for me, and to seek their expert opinion and have those good relationships with our colleagues. So to conclude this presentation, so we have discussed what claudication is and the main type, so the vascular, the neurological. We have shown how the patient's reported symptoms can help us differentiate from vascular and neurological claudication. We've discussed the risk factors to be aware of. Hopefully, from a point of view of the video you saw last week plus this lecture, you should be confident in incorporating vascular screening and assessment as part of your general MSK outpatient assessment if needed. And you should also hopefully be being able to understand when to liaise with the GP, healthcare colleagues, to help signpost these patients to get help. So these are just some references based on the studies that I've used. Thank you very much for listening. I hope you didn't fall asleep. And if you haven't liked or subscribed my channel, why not? And I'll be back next week and we will be looking at a different topic. Thank you.